Then comes one of the most common causes of cyanotic heart diseases with increased pulmonary blood flow, which is the complete transposition of great arteries, representing 5 to 7% of congenital heart diseases. This disease, the aorta, arises anteriorly from the right ventricle, and the pulmonary arises posteriorly from the left ventricle, resulting in complete separation of the pulmonary and systemic circulation, which runs in parallel. And to survive, this patient needs mixing on either the following levels: the atrial level, ASD by ASD, ventricular level through a VSD, or by a TGA. Some cases may have VSD as part of their pathology, and some cases may have left ventricular outflow obstruction as part of their pathology. This is a diagram showing the parallel circuits of the TGA, where the deoxygenated blood comes through the superior and inferior vena cava to the right atrium to the right ventricle, and then to the aorta to the systemic circulation. Whereas the oxygenated blood comes through the pulmonary veins into the left atrium, then to the left ventricle, and to the pulmonary artery to go on through the continuous parallel circulation. This results in severe cyanosis, and without any mixing at any level, the patient will not survive. Clinically, this patient presents with cyanosis since birth, and signs of congestive heart failure, as dyspnea and feeding difficulties, may develop later. By examination, we can elicit moderate to severe cyanosis. The patient is tachypneic with or without retractions, unless the patient will develop congestive heart failure in cases of a large VSD or a large PDA. Second sound is single and loud, with no heart murmurs if the ventricular septum is intact. If there is a VSD, we have this pansystolic murmur of the VSD. If we have left ventricular outflow obstruction, there is the ejection systolic murmur of the pulmonary stenosis. If the patient develops congestive heart failure, we can have dyspnea and hepatomegaly. ECG shows right ventricular hypertrophy since early days of life. Biventricular hypertrophy may develop with patients with large VSD or PDA. Chest X-ray will reveal cardiomegaly with increased pulmonary blood flow, with the characteristic shape of the egg-shaped heart. Echocardiography will show the characteristic features of the DTGA. Cardiac catheterization may be needed for balloon atrial septostomy to improve the mixing at the atrial level. It's rarely performed to show associated anomalies like coronary artery anomalies or collateral circulation or small aortic isthmus or coarctation. So what is the fate of transposition of great arteries if left untreated? These patients will develop progressive hypoxia and acidosis and heart failure, and results in death within the neonatal period. Most cases, 90%, will die before the age of 6 months. Patients with VSD and PDA are less cyanotic and more likely to develop congestive heart failure, but these patients are more prone to develop pulmonary hypertension and pulmonary vascular disease early by the age of 3 to 4 months of age. So any surgical intervention is recommended to be done before this age. The combination of TGA with VSD and pulmonary stenosis allows longer survival without surgical intervention. However, this is because it is protective against pulmonary hypertension and pulmonary vascular disease. However, this combination carries higher risk during surgical correction. So usually these patients come as an emergency. So At first, we need to stabilize the patient before doing any definitive intervention or even palliative procedure. At first, we need to correct the metabolic acidosis. We should start prostaglandin infusion to keep the patent ductus arteriosus patent and improve oxygen saturation. We should administer oxygen once prostaglandin E1 is started to decrease pulmonary vascular resistance and allow increased pulmonary flow and increase systemic arterial saturation. In case there is congestive heart failure in patients with VSD or large PDAs, anti-failure medications should be started. Balloon atrial septostomy, the Rushkin procedure, should be immediately carried out in case of adequate atrial mixing through the PFO, when the patient is presenting with low oxygen saturation and we are not ready for urgent surgical intervention. During this procedure, the balloon tipped catheter is advanced into the left atrium through the PFO. Then the balloon is inflated with dilated radio-opaque dye and abruptly and forcefully withdrawn to the right atrium under fluoroscopic or echocardiographic monitoring. This procedure creates a large defect in the atrial septum and allows proper intracardiac mixing. This will increase oxygen saturation by 10% or more, and this will be satisfactory until the patient is ready for surgical intervention. Definitive surgical repair in cases of transpositional great arteries include two types of surgeries. First, the atrial switch surgeries, which are the baffle operations like mustard and Senning. In these procedures, there is rerouting of the pulmonary and the systemic venous return at the atrial level, resulting in physiological correction. The pulmonary venous blood is collected through a baffle towards the right ventricle, which, according to the pathology, opens into the aorta, and the systemic venous return is collected through baffles to the right ventricle, to the left ventricle, which opens into the which already opens in the pulmonary artery. Thus, the venous blood goes to the aorta and the systemic blood goes into the pulmonary. Second is the arterial switch operation, which is the procedure of choice if done in the proper timing. Surgery requires good left ventricular size with good left ventricular mass and no left ventricular outflow tract obstruction. It's essential to do the switch operation as early as possible when this left ventricle is still trained enough to handle the high systemic pressure. The procedure entails mobilization and transplanting the coronary artery to the pulmonary artery, which will be the future aorta, and then the proximal great arteries are connected to the distal end of the other great artery, resulting in anatomic correction. This procedure has the advantage over the atrial baffle operation because it's anatomic correction with less frequent long-term complications.